Good morning, ladies and gentlemen. I would like to present to you my case report of challenges in CPR in patients with left ventricle assist devices. So let me start right away with the case presentation. 72-year-old man with implanted LVAD for severe heart failure was admitted to our hospital because of urinary tract infection and acute kidney injury. On the physical examinations, there was nothing significant, maybe only that the patient has peripheral pulsation, which is not very common in patients with LVAD. On the ECG, there was alternating sinus and pace rhythm. In the labs, there was hyperkalemia, renal impairment, signs of infection, and anemia. And the urine was positive for bacteria. We did some imaging studies. There was nothing significant. We treated the patient with standard therapy, and on the therapy, the patient got better. He was stable on the ward, and now I want you to imagine that you are a young doctor, and you are called in the middle of the night because of the alarming LVAD. So as you walk to the ward, you try to remember or recall what the LVAD actually is, and you know that it's a pump that is connected to left ventricle. It has some cables, drive-like cable, controller, and batteries. And you remember that there is a special circulation in this patient. There is usually no peripheral pulse. The oxygen saturation is usually unobtainable, and the blood pressure is measured with Doppler probe. And there are some usual adverse events, the major infection, bleeding, device malfunction, and stroke. So as you arrive to the patient, you see that one nurse is performing chest compressions, the other one is connecting external defibrillator, and the LVAD is still alarming, and the nurse reports to you that they found an unresponsive patient with no palpable pulse, no breathing, so they started the CPR. And I want you to tell you in your head what is your immediate response to this. Would you stop compressions because you can dislocate the device and harm the patient, or you order to stop connecting external defibrillator because it's contraindicated in LVAD patients, or you continue with compressions, you secure airways and breathing and examine the LVAD, or you do something completely different. So while you are pondering upon the answers, I want to tell you what the experts say and what are the guidelines for resuscitation in LVAD patients. So you call the resuscitation team as the first thing, and then it's recommended to do not start chest compressions immediately. Remember, LVAD is a very capable device. It can maintain circulation even in very unstable situations like ventricular fibrillation. So the next step, if there is someone else, try to secure patient airways, try to treat problems with breathing, and attach ACG or defibrillator. And then next thing is to look at the LVAD. So with any electrical device, try to look at the batteries, try to look at the drive line, the cables, if they are connected. If there is low flow alarm, remember there can be a problem with hypervolemia or major bleeding. If there are high watt alarm, suspect the pump thrombosis. And if ECG shows ventricular arrhythmia, don't be afraid to use defibrillation since it's not contraindicated. The next step is to assess circulation, and remember that in LVAD patients there are usually no pulsations, so you need to assess the circulation in different ways. So you need to use, for example, capillary refill, the cyanosis, or the look of the patient. You can try to measure blood pressure with the Doppler probe. You aim at the mean arterial pressure of 60 millimeters per mercury. If it's above, you likely have a normal perfusion. You listen to LVAD sounds. The LVAD sounds like a hum, so that's another thing you can look at. And if you think that the circulation is okay, you continue with ABCDE assessment, and you try to exclude stroke as the main priority. And if you think that the circulation is not adequate, you continue with standard CPR. And remember, echo is always a good option. So let's get back to the patient. We continued with chest compressions. We called the resuscitation team. We secured the airway. We ventilated the patient with a bag mask. The device was checked. There was low flow alarm. The cables and otherwise the controller seems to be fine. There was paced rhythm, so non-shockable. The patient was cyanotic. We tried to measure the blood pressure, but we failed. So we continued with CPR. We administered epinephrine. And after the resuscitation team arrival, the patient was intubated, and we had peripheral pulsations after another administration of epinephrine. And we examined the patient with bedside echocardiography. There was nothing significant, but on the physical examination, there was anisocoria, so we ordered head CT, and it showed a large intracranial hemorrhage of occipital lobe. The neurosurgery was not indicated, and we started palliative care. So I would like to conclude that the number of patients with LVAD is increasing, and we need to be prepared for these emergency situations. Remember that the care of these patients is very specific, so don't be afraid to call LVAD coordinator. We should be always on the phone. Remember special circulation, and remember if the resuscitation is happening, do not start compressions, chest compressions immediately. Try to secure ventilation and airways. Check for the device malfunction, and if you think the circulation is impaired, don't be afraid to use standard CPR. And I thank you for your attention.
Thank you, Tomáš. We have just a couple of minutes for discussion. Any question from the audience? I just would like to start. So your patient died because of brain hemorrhage or because of septic shock?
Because of brain hemorrhage, we think.
That's challenging because...
Yeah, it is, but I want to like to comment on it. It's just based off the low flow alarm, I think, because and another thing is that the patient was like stable. His CRP markers and everything. He did not have fever, but yeah, it could be that the patient had septic shock. Yeah, sure.
That's my opinion. I mean, at the end, hemorrhage in these patients you can really have as consequence, but you cannot die for hemorrhage. I think he's died because it was a very severe septic shock.
Okay,
that's
it could
my
be.
Opinion.
It could be.
Any other question?
If there are not, we can move on.
Okay, let's move on. Thank you very much,
Thank
Tomáš.
you. So